Thank you for inviting me to speak, and I'm really have enjoyed both Dr. Singh and Dr. Asher's talks this morning because I think they said something that is so important for survivors. And what Dr. Singh was talking about is second opinions, but even more importantly, expert opinions about what's happening. And when Dr. Asher started talking about Dr. Franco, he's been one of my favorite philosophers since I discovered him when I was a freshman in college, actually 50 years ago. And I think what he says can be transcribed into the survivorship world. If you take what he said and the meaning of what he said, you can't take away the fact that you've had cancer. But what you can do is change your life at this point to address what you're going to do from having that cancer diagnosis. So I think both of that expert opinion and that you are in control of how you can change how you react to having had that cancer diagnosis is a really good way to start out talking about cancer survivorship. Now let's see. There we go. No disclosures, just some objectives. So just to give you a little bit of an idea, and I'll give a disclosure, I should say, I am not an expert at all in survivorship that occurs in people over the age of 40. So my whole experience is related to people who have been diagnosed under that age. So most of my comments and things that I'm going to talk about are related to people who were less than 40 at the time of their diagnosis. And looking at the people in the room, I would make a guess that's where most people are. Am I correct? Where most of you that have a cancer diagnosis under the age of 40 at the time of your diagnosis? See some hands going up. So what do we know about bone and soft tissue sarcomas? We know that they can occur almost anywhere in the body because those tissues that they arise from are everywhere in the body. There can be benign tumors, meaning that they are non-cancerous, and benign tumors typically stay localized, so they don't have the ability to spread to other parts of the body. Malignant tumors are the ones that are classified as sarcomas, and they can spread to any area of the body, and depending upon the type of sarcoma, one of the most common areas of spread are the lungs, lymph nodes, bone marrow, and even other bones. And so this is just an example of somebody who had an osteosarcoma, a tumor of the bone, that had a spread to the lungs. We know there are over 50 different types of soft tissue sarcomas. Things that we think about are rhabdomyosarcoma, synovial sarcoma, but there are many, many more. Osteosarcoma is a malignant tumor of the bone, and it is the most common bone cancer in children and AYAs. Ewing sarcoma is the second most common sarcoma in children and AYAs, and it can be either a soft tissue sarcoma, a bone tumor, or both. And this is just an example of a patient I had many years ago who presented, he was about 8 years old, presented with a mass on his right upper leg, and that's just an x-ray of that. And this young man did indeed have a Ewing sarcoma. What can cause a sarcoma? There can be sarcomas that are related to radiation exposure. We do have some patients who were radiated for a different type of tumor and ended up having a bone sarcoma. There can be genetic predisposition and family cancer syndromes. We know that people who have neurofibromatosis are at greater risk of developing sarcomas. People with retinoblastoma are also at greater risk of developing sarcomas. Li-Fraumeni syndrome is a genetic disorder that puts you at greater risk for developing any type of cancer, actually. What do we know that does not cause sarcomas? We know that an injury and your lifestyle, such as diet, smoking, and exercise, do not cause sarcomas. And I can tell you in my years of practice, I've had so many parents say, well, you know, this tumor came up after they were hit in the leg by the baseball when they were playing baseball. Well, that didn't cause the tumor. It might have led to the diagnosis because potentially they had some bleeding into a tumor that had started to grow, and so they've had increased pain and swelling that occurred shortly after that injury. But the bottom line is, at least in the pediatric and AYA population, we do not know what causes most sarcomas. We do know that radiation exposure can put you at greater risk, as I mentioned previously, and again, that genetic predisposition. Oh wait, this is, so sorry, it didn't move forward. 20% of pediatric solid tumors are in the sarcoma family, but less than 1% of adult malignant solid tumors are actually sarcomas, and they do increase in frequency after the age of 50. So the general incidence, there are about 12,000 people diagnosed with soft tissue sarcomas each year, and that's in both children and adults. Excuse me. They originate in soft tissue, but may include bony involvement, and arms, legs, chest, and abdomen are the more common areas. There are about 4,000 primary bone sarcomas that occur primarily in children and AYAs. Again, they can originate in the bone, but may have a soft tissue sarcoma, a soft tissue component. And they're more common in the femur, humerus, fibula, and ribs. So treatment is surgery for pretty much all sarcomas, whether it be a bone or a soft tissue. Surgery is a critical part of the treatment plan. But depending upon what is suspected, it could be that the original treatment is biopsy, and then chemotherapy plus minus radiation, and then surgical resection of the primary mass. But that's very dependent upon the type of sarcoma as to what the plan is. Surgery may include amputation or limb sparing procedures. And I know that earlier in the conference you had talks on those types of procedures. Chemotherapy is used for almost all sarcomas, whether they be bone or soft tissue. Depending upon the type of sarcoma, they may or may not use radiation therapy. For example, people with osteosarcoma, radiation therapy is not part of first-line treatment. And radiation in general is going to be more common in tumors that are involving soft tissue. And this is just an example of a surgical procedure. This was a patient that I had about 30 years ago who was very early with the limb salvage type procedure, where they, instead of amputating his leg, he was able to have the procedure done where the tumor was removed and then had an artificial knee placed. And this young man was pretty amazing. His hobby was rodeo, horse riding, and he participated in all these rodeos and trick riding and etc. And he went on to do this after he had his surgery and was done with his chemotherapy. So why do we care about late effects of treatment? If we lump all sarcomas into one category, the overall survival is somewhere 60 to 65%, but there are some types of sarcomas that have cure rates approaching the 90% area. The bottom line for the patient, it's either 0 or 100, so it's not a big focus on what are statistically am I likely to have occur, but the reality is what happens to you. The survival is really dependent on the tumor type, the stage, and whether or not there are metastases. And this is an example. This patient actually had a little bit of an unusual type of situation. This patient had an osteosarcoma that was primary in his distal femur, and it spread to multiple areas of the bones. So what are late effects? Late effects are complications that either persist or arise after all treatment has been completed. And a late effect may influence not just the quality of life that the patient has, but the quantity of life. So what are the risks of having a late effect after treatment or a health problem after treatment? There are some things that influence that, gender, because there are differences in late effects based on whether you're male or female, particularly related to things like fertility issues. What was the pre-existing health issue? Did you have other health comorbidities? What's your general nutritional status? What's your body composition? What were you at the age of the time of treatment? And what's your current age? And not just your current age, but your current lifestyle behaviors or patterns. What were the specific treatments used and the doses received? What area of the body was treated with surgery and or radiation? So all of those are really important to guide us in figuring out what potential late effects someone may be at risk for based on their treatment. So how do we determine what to look for? So the screening is based on what the treatment was, and we refer to those as treatment exposures. The Children's Oncology Group, which is an international organization that develops treatment for all types of pediatric and AYA cancers, has developed guidelines for looking at cancer survivors. How do we know what to do? How do we know how to screen them? How do we provide the appropriate care after people are off treatment? And this is actually the front page of our guidelines, and these guidelines are on the public website under survivorshipguidelines.org, and anyone can look at them and anyone can utilize the resources on that website. And that website is developed by the Children's Oncology Group. So this guideline gives us the screening, not only the recommended screening test, but how often should we do them? And what are things that we need to consider if we're going to, do we need to refer a patient to a specialist for a particular area? And the guidelines also include a lot of health education. So this is just an example of a page in the guidelines. So if a person had an amputation, the guidelines are going to tell us some of the things that we screen for, such as phantom limb pain, psychological adjustment, etc. If the patient had a limb sparing type of surgical procedure, things we're going to screen for are going to be like limb length discrepancy. And I believe Dr. Zuckerman from City of Hope did a talk about that yesterday, and it's amazing the innovations that have occurred. As was said when I was introduced, I've been working in this field for almost 50 years. And when I first started working in the field, people with sarcomas, particularly ones of the lower extremities or the upper extremities, the only treatment was amputation and then chemotherapy. But things have changed so dramatically, and it's really remarkable to see what the innovations have done to improve the quality of life for people. Things that people who do have a limb sparing procedure, they now have artificial hardware in them. So you have to think about, are there issues that put them at higher risk for infection? Are there going to be any issues related to pain? If they do have an artificial joint, do they need something called endocarditis prophylaxis? That's where you take an antibiotic prior to having invasive dental work, or having, say, a colonoscopy where you're manipulating tissue that is very vascular, because if you get bacteria into the bloodstream, normally your immune system eradicates it, but when you have artificial hardware, that bacteria might go want to hang out and on the artificial joint, and then ultimately cause a serious infection. So there are a lot of different nuances that have to be looked at, and the education, of course, is going to be based on the individual patient. So when we look at chemotherapy and the potential late effect screening, we actually classify things based on the class of chemotherapy agents. And for those of you who have had chemotherapy, you may recognize many of these agents. Alkylator agents are things like cyclophosphamide and ifosfamide, maybe irinotecan, melphalan, platinum agents such as carboplatinum or cisplatinum, taxotere, etc. Another commonly used chemotherapy for people with sarcomas are drugs called anthracyclines. Adriamycin, also known as doxorubin, is the most common one, and I always tell my patients that's the one that looks like cherry red Kool-Aid. So people often can remember that one because it's really the only chemotherapy that has that vibrant of a color. Antimetabolites are things like methotrexate. Anti-tumor antibiotics are actinomycin. Some of the miscellaneous are things like etoposide or VP16, plant alkaloids like vincristine. There are a lot more agents too. And I did not go into any of those, but it's the newer agents that are called monoclonal antibodies. So there are things that are out there besides the standard chemo. We don't have as good of knowledge about screening of late effects for the monoclonal antibodies, also known as MOHABs, just because of the length of time they've been used, and not just the length of time they're used, but now we need a very lengthy period of time since people completed treatment to see if we are seeing any issues from those agents. So when we look at screening, we look at cardiac. The category of drugs that can affect your cardiac function are the anthracyclines, and the late effects they can cause are things like arrhythmias, cardiomyopathy, or congestive heart failure. And we screen by EKGs and echoes. The frequency of that screening is related to the dose. Higher dose, more frequent screening; lower dose, less screening. When we look at the reproductive system, alkylating agents are the primary culprit, so the ifosfamide, cyclophosphamide. It is cumulative dose related, small dose, low risk of having infertility or fertility issues. Higher dose, higher risk. So the late effects we see are infertility, and for females, premature ovarian failure, meaning that a female who receives these agents may go into premature menopause. They may go into menopause in their teens, early 20s, early 30s. Again, it's very dose related, and there are ways to evaluate that from the get-go. The other issue, though, that it can cause is sexual dysfunction. So things like decreased libido for males, erectile dysfunction, etc. And those are both things to assess patients for, because there are treatments and options to help improve those deficits if they occur. So screening, it may include hormone testing. It can be assessing how many eggs or ova does a female have left in her ovaries. Males, it's very easy. Since the late 1950s, you've been able to do sperm counts. Female fertility preservation is much newer. It's in the last 20 years that you've been able to preserve an egg or ovarian tissue. It used to be you could only preserve an embryo. And what 14-year-old girl diagnosed with an osteosarcoma is going to know who she would want an egg fertilized by to have an embryo. So with the advent of being able to store eggs and ovarian tissue is really changing fertility preservation for females. The platinum agents can affect hearing, and they can cause also tinnitus, the ringing in the ears, which can be very distressful. We assess that by audiogram, but also history. And so like for my kids that are still in school, one of the questions I always ask, are you having any trouble hearing the teacher? Where do you sit? Do you sit in the back of the class? Do you sit in the front of the class? So things like that can give you an idea, in addition, of course, to the audiogram. Some of the neural effects can be related to a drug called methotrexate, which is commonly given in very high doses for people with osteosarcoma, and that can cause neurocognitive deficits. It does not affect your IQ or your intelligence, but it may affect your executive function, particularly things like short-term memory and speed of processing. So we do a school and work history. And we recommend neuropsych evaluation, and neuropsych evaluation assesses how you learn, identifies your strengths and your weaknesses, and they can give you strategies of how to use your strengths to help compensate for your weaknesses. We also have side effects that are related to peripheral neuropathy. Vincristine is the major culprit. Some of the platinum drugs may cause that, but peripheral neuropathy is usually numbness, tingling, fingers, toes, sometimes jaw, chronic constipation because the peripheral nerve cells in the GI tract are sluggish. Urinary complications can be related to cyclophosphamide and ifosfamide, and they may cause hemorrhagic cystitis. I'm happy to say that's less and less of a problem because we have agents that are given at the time you receive the ifosfamide and cyclophosphamide that help prevent any damage to the bladder. And so less of an issue than it used to be in years past. So again, we screen by getting a voiding history. Are they have any problems with urinating? Do they have blood in their urine, et cetera, and a urinalysis. Renal is when it looks at, have the kidneys been harmed? The platinum agents and ifosfamide are the chemotherapy agents used for sarcoma that have the greatest risk of harming the kidneys. And it can involve general renal toxicity as well as hypertension. And we do a basic metabolic panel for screening. We look at the magnesium level and we check blood pressures. Now I'm going to talk a little bit about radiation late effect screenings. So if the field is the head, you're at risk for problems with the eye, the jaw, and the neck. So if the eye, it's a higher risk of cataracts. And so we recommend yearly eye exams by an eye doctor, either an ophthalmologist or an optometrist. The jaw can cause dental abnormalities, including excessive cavities, periodontal disease, dry mouth. Again, we recommend a minimum of every 6 months dental care, and if there are problems identified, it might be quarterly dental care. If radiation affects the chest, that can affect the heart, and so it might affect the blood vessels that supply the heart. It might affect the heart itself or the heart valves. So a carotid artery exam and ultrasound, we're listening for our blood flow to the brain. An echocardiogram tells us how well the heart works as a mechanical pump, but it also tells us if the valves are opening and closing properly. And the frequency of those assessments, again, are based on the dose that the patient received. Other issues with the chest include lung disease. So again, a history. Can you walk up a flight of stairs without getting short of breath? Are you excessively fatigued? And we do pulmonary function tests. For females who have not developed their full physical breast development, so a younger teenage girl or even a younger girl may have breast tissue hypoplasia where their breast tissue does not develop normally. And then they are at higher risk of breast cancer. If a female has radiation that includes her chest, she starts breast cancer screening at age 25 or 8 years after the radiation was given, whichever occurs last. If radiation is to the abdomen, there can be liver toxicities. There can be metabolic disorders that occur. And those metabolic disorders can include type 2 diabetes, can include high cholesterol, high triglycerides, et cetera, and abnormal liver function tests, which is what the LFT stands for. Other issues that occur from radiation to the abdomen and pelvis, you can have bowel obstruction issues. So again, history, potentially an x-ray if a person has some type of abdominal symptom. Colon cancer is more likely to occur in someone who has had their GI tract radiated. And just as the general population, colon cancer screening dropped from age 50 to age 45. In the oncology world, we used to screen patients who had abdominal radiation starting at age 35. We now start that at age 30 and are 5 years after the radiation, whichever occurs last. And that colon cancer screening, unlike the general population, which is every 10 years, for the patient who had radiation to their GI tract, it's every 5 years, or if the GI doctor recommends it more frequently, then that recommendation is what would be done, but no greater than 5 years. The other thing that can occur that primarily affects females, of course, is uterine insufficiency, which means that they may be able to get pregnant, but their uterus has been hit by the radiation and their uterus loses its elasticity. And so as the fetus is growing, the uterus may not be able to expand, and it can lead to premature births and early miscarriages. Both in females and males, you can have sexual dysfunction. And again, we also screen with hormone testing. So I put in here some of the questions that I'm often asked by patients. Does treatment automatically mean I will be infertile? And the answer to that is no. It's based on the cumulative dose of the chemotherapy agents that cause infertility. And again, not all agents cause infertility. You may have had therapy that has no impact at all on your potential fertility. We also know it has to do with the age you were treated in females. If a female is treated prior to going through puberty, they have better fertility preservation. Unfortunately, in males, it doesn't matter. There's the same degree of infertility whether they were treated pre-puberty or post-puberty. Another question I often get asked, are there options to maintain fertility once treatment is complete, especially if I was unable to do egg or sperm banking? And there are some options for some people. So it has to be addressed on an individual basis. Whenever I see a patient, especially a young woman in her later teens and her early mid-20s to 30s, I highly recommend that they see a fertility specialist. They can do something called a high-resolution ultrasound to get an idea how many eggs are left in that person's ovaries. If they have a normal egg count for their age, probably nothing needs to be done. But if you've got a 25-year-old who has very few eggs, those eggs aren't going to be hanging around for a long time, and they may go into menopause before they're 30. So that might be a patient who wants to have their eggs retrieved and frozen so that if they do go into early menopause, that there is the option of being able to have a biologic child. I suggest semen analysis or sperm counts for males. I rarely have males that will do it before their early mid-20s unless they do it because their mother wants them to do it. But the one thing I do recommend is do not do that sperm count too soon. I can't tell you the number of male patients that will tell me, oh yeah, I had a sperm count when I finished chemo and I didn't have any sperm. Well, that's not unusual. You need to be off therapy a minimum of a year and preferably at least 2 years to see if you do have sperm recovery. And I have quite a few patients who down the road when they rechecked the sperm count actually had sperm, but when they had it checked at the time they completed chemotherapy, there was no evidence of sperm. But the other thing that's important about a sperm count is patients may have sperm. They don't have a lot, but they have sperm. But they also look, what's the motility of the sperm? Is the sperm active? In male patients who have sperm that have very low motility, sometimes what needs to be done is to harvest that sperm and then use insemination to achieve pregnancy, because the sperm on its own and through just intercourse may not be active enough to be able to fertilize an egg. So options are out there, but you have to look for them. And sometimes people don't ask you about them. So who should I see to evaluate potential fertility? There are a lot of fertility specialists out there nowadays. 10 to 15% of the general population has infertility issues, but the person who's been somewhat lacking have been the male fertility specialists. And now we do have male fertility specialists. And I think that's the key person for a man to see. And I know UCLA has a good program. There are other centers that have good programs. But just as was said earlier this morning, that expert opinion is crucial. And sometimes you need the expert opinion and not an opinion from a generalist. And then a huge, huge question. What is the risk of my child developing cancer? Well, in the world of pediatric oncology, we now not only have enough childhood cancer and AYA survivors that have children, they have grandchildren and even great-grandchildren now. The incidence of cancer in the offspring of a cancer survivor who does not have a genetic disorder is the same as the incidence of cancer in the general population. And so I think that's really important. There was a time in my professional career that actually people were told differently. Oh, your child might be at greater risk if you're even able to have children. I've also had patients who have been told by, oh, you'll never be able to have children. And we need to do a lot of education. Your ability to have children is really based on the treatment that you received. And that's why having that consult with the specialist is so important. So what can you do to maximize your health? You need to make healthy lifestyle choices. Have a healthy diet, healthy weight. And the key is now not just what you weigh and what your body mass index is, but what's your waist measurement. The current recommendation is that your waist measurement should be no greater than half of your height measurement to ensure the best cardiovascular health. So if you were 10 inches tall, your waist measurement should be no greater than 5 inches and preferably closer to 4 to 4.5 inches. It's important to have exercise and daily exercise. And it doesn't mean you have to go to the gym. It's when you go somewhere, don't park next to the building, park further back so you walk further. Take the stairs. If you happen to live, your home has stairs, you got an automatic Stairmaster in your house. You can run up and down your stairs, like for 10 minutes, 2 or 3 times a day. So walking, dancing, cleaning, jogging, gardening, lots of things give you exercise. It's important to have a PCP, a primary care provider, so that you can have your general health issues addressed. If possible, attend a long-term follow-up program. In the pediatric AYA world, the long-term follow-up or late effects programs that I work in are now considered a standard of care, and patients are routinely referred to these types of programs. In the adult world, those programs aren't as common, they're more difficult to find. The guidelines for the adults aren't quite as robust, although they do have them. In our program, we see patients diagnosed prior to the age of 40, and we use the Children's Oncology Group guidelines because we think they're appropriate for that young adult who was treated. But the other key thing is become your own advocate. And I would say that people who are attending a conference like this are probably good advocates for themselves, or if you're a parent of a patient, you're becoming the advocate for your child. And it's important for you to have knowledge and be able to share that with your healthcare providers. I had this treatment, I'm at risk for that, that sort of thing. So just as a kind of a plug for our program, we are a clinical research program. It is a collaborative team. When a patient comes to see us for the first time, they have whatever are the appropriate diagnostic tests based on their treatment. They are seen by primarily me, although we do have patients seen by one of our oncologists. They're also evaluated by a psychologist to see if there are any psychosocial issues, and as well as our dietitian. Currently, our program is grant funded, so there is no billing to the patient or their insurance. There's my timer, out of time. And the referral process, you do not have to have been treated at City of Hope. There are some programs that you have to be treated at their center to be ordered to go to their late effect programs. Patients can self-refer. Claudia Herrera is the research assistant who coordinates everything in our program. And that's her contact information, her email, as well as her phone number. So the criteria to be eligible for our program: you have to be less than 40 years old at the time of diagnosis. You have to be in remission and off therapy for a minimum of 2 years. And there's no upper age limit. Ironically, in our program, I'm currently 68. I have 2 patients that are older than me. I have one patient who was diagnosed in 1950, and I have another patient who was diagnosed in 1954, and we followed them in our program. So if anyone is local and meets the criteria, we would be happy to have you come to our program. When you do come to the program, you also receive a concise summary of your treatment that you're able to share with your other providers. And if we do find a problem, then we refer you to the appropriate specialist. That referral would have to be through your insurance, so wherever your insurance would direct you to go for that. As I mentioned, you get a personalized treatment summary that's very specific to you, and then to what your risks are and what screenings you should have done. And Julia Rowland used to be the director of the Office of Cancer Survivorship at the National Cancer Institute. She is now retired. But she says, being cancer-free is not the same as being free of cancer. And so I think that's a really important message. You may no longer have cancer, but you need to take care of yourself in a way that's probably even more important than someone who has not previously had cancer. And this is just a copy of a gate that's in our garden at City of Hope. And it's kind of the philosophy of City of Hope. There is no profit in curing the body if in the process we destroy the soul. And so I think the message is it's the whole person who needs to be taken care of, and not just a certain body part. Thank you very much.
Thank you, Karla. We have time for a few questions. Are there any here in the room? Are there any online, Kelly's?
There's one question online. Does uterine leiomyosarcoma diagnosed at 36 qualify for this late effects program? Wanted to clarify what pediatric type comment on the slide.
I'm sorry, I didn't hear the type of cancer.
Uterine leiomyosarcoma?
That may not, because that's not traditionally what's considered a pediatric or adolescent. That sarcoma, that would be someone who might need to be treated in an adult, maybe a GYN late effects program. I would actually have to see the records to know for sure if that would be someone who would be eligible for our program.
Thank you.
Any other questions? Thank you.
Thank you very much.